There we go. Yeah, so lots of time together with the WFMT. I won't touch too much on it here, but before I get started, I just did my thesis and I looked at the experience of Arab music therapists and their education and training, and had a lot of regional music therapists engage in that study. So it might be something interesting to collaborate on in the future, to like do it in different regions.
Yeah.
But that's not why I'm here today, but that thought in my mind. So I was like, I need to speak it into happening.
Yes, yes.
Um, maybe. So today, though, we're talking about palliative care. I know all of y'all have done quite a few weeks already, so I think you probably have a pretty solid understanding of what, in general, palliative care is. My work specifically focuses in pediatric palliative care. So working with those children and young people from birth to around 18 years old. And I started that, as was mentioned, in the States, but also predominantly in Kuwait, a little bit as well in Qatar. All right, so a little bit more just of my intersecting identities and my background, just to let everyone know. I'm a white American, American from European descent. I'm English speaking only. Also a cis woman. I've practiced for about 12 years over the areas that were previously mentioned. Some exciting news, actually, I realized after I sent you my intro, the second edition of Music Therapy at the End of Life just got published a couple weeks ago, actually at the beginning of this month. And I was able to offer one chapter about cultural considerations for music therapy with Southwest Asian patients in Kuwait at the end of life. So that was very exciting, my first ever published material. And the book, it's a very, very thorough, very broad book. I know palliative care and end of life, there is some overlap. So for those who have interest in music therapy at that stage, it might be something y'all would want to check out in the future. It's in digital and print. And I was just mentioning, I am almost like so close to finishing my master's right now in music therapy and counseling at Slippery Rock University, and just defended that thesis. So that's a little bit about me to kind of situate myself, because I'll be talking mostly about working with people who are not American and also not white. So I know we're only a few today, because Bhavana mentioned that a lot of people will watch this later. So what kind of professionals? I got a little bit of background, some other medical professionals, some people who are musicians, some music therapists. So does anyone else have a different profession who's in here than that would like to share? I think there's only, there's
Yeah, there are some of them. I think we also have some from the engineering background as well, who are interested in listening to us in. But you can send in your information on the chat if you would want to share what professions you are from.
that'd be so helpful, because palliative care is such a niche-y thing. So if I'm getting too specific, please type something in the chat. I'll try to keep my eye on the chat and pause and answer something if it's not clear. So nice. I see someone is a research scholar in Indian music. Amazing. Happy to have you here. So let's go. Let's keep going then. So before I dive into all the music therapy bits, I wanted to start off with just a very broad information about systems theories. So I find, especially working in pediatric palliative care, but I think in any palliative care, being aware of all of the different systems that our participants are a part of. So how are the different relationships between people in those systems? And when we come and we look here at that smallest system, this is Bronfenbrenner's ecological systems theory, but it has a nice visual, I think, of we have the individual who is part of their own individual system, their health, their age, their sex, that system that keeps us and our bodies going, our identities, what our gender identification might be, what our ethnicities, right? Our cultural intersections, we might find that there. And these systems keep going out to our families, to other relationships, maybe beyond that, acquaintances. We have then our neighbors, social services, social medias, right? And we keep going out, and how all these different systems interplay. So also keeping in mind how an individual might move through each system, and how if someone changes, that might impact how they move through a system. I think a small example where that's not healthcare related is, me as a person, I love to go get coffee with my friends and sit outside and enjoy that with my peers. I adopted a dog a few years ago when I was living in Kuwait, and the culture around pets, specifically pet dogs, is very different than American culture with dogs. So there's many places where dogs wouldn't be welcome to sit outside and have a coffee. So that kind of changed how I navigated through different systems. If I wanted to bring my dog for a coffee, right? I had to look at other coffee shops, look at other places, get my friends on board. Hey, what if we switch up where we go? And how we navigate the different systems around us. It's a very simple example, but we'll go into a bit more specifically in healthcare. So, what I'm going to chat about today in relation to pediatric palliative care is the healthcare systems that our participants may be navigating, the family systems that they're navigating, and then how do we support as music therapists as our participants are engaging in these systems, right? How do we set our goal? How do we assess? How do we do the work within all these different moving components that are systems? And then we can just kind of tie that up if there's any questions or anything like that. So when we start with healthcare systems, no matter where you're working and supporting pediatric palliative patients, as a music therapist, you are a part of that wider healthcare system, whether you're in the hospital, in the home, in a developmental clinic, no matter whether you're in your own private practice, right? You are, in effect, part of that wider healthcare system. It is huge. It is vast. I can't speak on the healthcare system in India. I've been to one hospital in India. I had my nose pierced. It was a very simple walk in and leave. But I can imagine with the large population and the variety of healthcare services, it is huge. Not only do you have specific communities and ailments and various needs over large, wide areas, but then you have certain services that are only available in certain geographical locations. And I found, not only in the US, but also working in Kuwait, that this adds sometimes a burden, right? If a palliative patient, typically pediatric palliative patients follow many specialists, not just one. So this is a huge burden on that participant and their entire family unit of how they access these cares, these services, where they go, how often they can go. This just adds to the complexity, which is another part that I want to point out. The financial burden that falls on pediatric palliative patients is quite heavy. Now, if you're not in a place where these services are provided for you by the government, or you're not in a position where you have healthcare, health insurance, I'm not sure again in India how the funding for healthcare works, but the US is a very privatized healthcare system, whereas in Kuwait, the government does pay for citizens. And it is quite a lower cost even for those who are residents. But still, depending on that bracket of where that children's parents' salary lies, has a huge impact, right, on how often and what they can access. And it's also complex by referrals. How many referrals do our palliative patients get? It's like one ailment, it's like a domino effect. So it can be quite daunting, quite overwhelming, the complexity of navigating a healthcare system. And I think especially for parents who have children who have palliative diagnoses, it's unknown. And especially if it's the first child they've had or their first sick child with a chronic illness. It's a lot to take on, and that child is kind of, or young person, teenager, they're kind of on for the ride, being kind of in this tornado of different clinics, people, faces, hospitals, you know, in a short period of time, especially at that time of diagnosis. So when I'm taking my framework from a feministic or critical lens, critical theories lens, I look at this, what is oppressing those who are in it? All these barriers that I've mentioned, you know, geographical location, financial, hey, even language barriers. There's so many people who migrate, immigrate for healthcare or for other reasons, where a language barrier, doesn't matter where in the world you are, you're going to have people who struggle to communicate within the healthcare system. What else do I have on here? Yeah, I think another oppressive factor in the healthcare systems I've personally worked within is that there's a very curative approach to health and wellness, especially in palliative care, a huge focus on making it better and not always in that comfort care. And I think that this initial inclination of some healthcare professionals creates feelings of hopelessness, helplessness, of feeling invisible, of feeling like they must be fixed all the time and not being seen as a whole person, but always as an ill person. I don't know if you noticed, but I'm trying to use the word participants and not patients, especially within the music therapy world. When we want to try to even out that playing field and that dynamic of power, in the healthcare system, they're patients. There's really no way around that unless you work in the most amazing facility. I want to know about it. I want to be there. And when we're already labeling someone as a patient, we're already putting ourselves above them in that power dynamic. So I just want us to keep in mind every single palliative patient, whether it's pediatric, adult, these systems are difficult. And as music therapists, we're also part of that system, and we need to be aware of what some of those oppressive functions of that system might be. So then we go into family systems. They may be more complex, depends. Families, especially when you're working in pediatric palliative care, play a huge role in our work as music therapists. They dictate how we assess, how we set goals, how we implement our interventions. So we really have to understand how every participant we work with and every family member, how do they relate? How do they function? So I loved this the way Walsh mentioned this in one of her articles, which all my references I'll put at the end. So I just wanted to quote it. And the ecological and developmental perspectives, they're interwoven in viewing the family as a transactional system that functions in relation to its broader sociocultural context, and it evolves over the multi-generational family life cycle. So when we think of the family system and we think of our pediatric participant, what does that family look like around them? Do they have one parent, two parents? Do they have, what are the sexual orientations of their parents? What are their genders? What other oppressive things might be around those parents? What is their socioeconomic status? How does that impact how they're able to engage with that child? What is their view of health and wellness or illness? What was taught to them by the grandparents, right? And what are those beliefs and values that continue to be handed down through that family line? And it's not what is an entire culture feel of health and wellness. That's the broader system. We're talking about that family and what their beliefs and values around things are. So something we need to keep in our mind, and as we assess what kind of trauma has happened within that micro family unit, and then maybe in generations past. We don't want to assume they're traumas, but we don't want to assume they don't have any. So being aware that there might have been some trauma experienced, and that might affect how different persons in that family relate to each other. Are there siblings? What's the age gap between siblings? I think another aspect of the family system when we're talking about palliative care is also the chosen family versus someone's birth family. What are the caretakers in that family? Are they the biological parents? Are they adoptive parents? Are they caretakers? The parents just really aren't able to take care of a sick child. So maybe they've chosen other people in their communities to come along with them on that healthcare journey. I know especially in Kuwait, there are very large family units than we're used to in the States. Majority, there are still lots of very large families in the States, but majority families on average are quite a bit smaller than the average family in Kuwait. And we've had patients who are like maybe the youngest, or participants who are the youngest, and their parents are quite elderly. So they might have an uncle or an older brother be part more of that parental figure throughout their healthcare journey. So just being aware every family unit might look different. Another big part of the relationships between family members is how do families address conflicts? Are they a family who puts it all out on the open? Are they a family who maybe puts negative feelings or what we might term bad feelings under the rug? And let's just not talk about that. Are they a family where, argument might spark up quick, right? People get defensive quickly. I mean, there's so many different ways that people can address conflicts. How does this family we're working with do that? And the intersecting identities of each participant. So why I bring that up is, especially when we're talking about young people and children, and then the parents, how do the parents view their identities versus the children? When I was working in the States, we had a lot on our pediatric palliative caseload, a lot of immigrants coming from South America or Mexico. So I worked with a lot of Spanish-speaking first families, and the children, however, were born in the United States. So there was a different cultural identity from the parent to then the child. And how do we honor all of those identities for all parties, right? And maybe bring awareness to why certain conflicts may arise because of that. Same in Kuwait. It's all actually all over the Gulf. There's so many residents throughout the Gulf that are not citizens. I'm sure almost every one of you have some family, a distant family or friend who probably relocated to Dubai or Abu Dhabi, Kuwait for a job. It's a huge influx of hiring. And then they have children here in this region, right? We call like a third culture kids. I don't know if y'all have heard that term. You have your parents' culture, you have the culture of the place you're living, and then you have that child's intersecting culture identity. So I think especially when working in pediatrics in general, but in pediatric palliative care, what does that look like for all the participants in that family? Yeah. All right, now into the fun stuff of music therapy. Um, so there's obviously so many approaches to music therapy support and how one might do that. Um, I think when we're working in hospital settings, medical settings, it's very easy to gravitate towards a medical music therapy model, which has a lot of value. I'm not going to touch on that today too much. Hopefully someone else has, and you'll have that information. I want to focus on some of the other approaches that are a bit more rooted in the feministic and critical theory, as well as social justice frameworks, because I think a lot of the pediatric palliative participants and their families deal with a lot of discrimination within different systems. So community music therapy, for those who don't know, is an established approach to music therapy where we are looking to use the music therapy space within different communities or within a community to promote change for social justice. So you might think, how do we do that in palliative care? Like they're sick, they need medicine, they're coming for comfort, right? But how do we make the system better? When I spoke about the healthcare system and some of those things that were oppressive in nature, how can music therapy help to kind of chip away at some of those discriminating pieces? So some of the work that I've done as a music therapist and also in collaboration with other psychosocial professionals is support groups. So support groups can be a great way to bring people of various intersecting identities together, but they have one thing in common, right? They have either themselves a palliative diagnosis or they have a loved one with a palliative diagnosis. So when you're looking at the vast and complex healthcare system, how people navigate it, how people find community, it can be done through creating that music therapy space. So you can do support groups for parents, for grandparents, for caretakers, siblings, for the ill person themselves. And when we have the act of bringing those people together to set those goals of what they want to work on, to find commonalities, to find a space to bond and connect with each other, that within itself is acting as a space to push against a healthcare system that may not offer that space. A lot of times when you go in, you're just one-on-one with your doctor. You're not meeting other people really at a hospital unless there's a bunch of people in a waiting room, but it's quite short-lived. So what about an intentional space to meet each other? I think a big one in pediatric palliative care that I've seen a lot of needs and the teams I've worked on is parent support groups. Caring for a child with a palliative diagnosis is so difficult. it requires so much energy, so much self-compassion as a parent, and so much resilience to keep that strong face, that face of optimism when your child might be going through a low health period. So having parents come together and use music as a way to express those challenges, to come up with ways together to build on ways to get through, and maybe you're not going to get rid of the challenges. You have to live with some of these challenges, but you can maybe reduce their impact, and through that building resilience. So that can be, just as well through improvisational music making. Community music therapy doesn't dictate the kind of music or the style of music. It's the act of the community that comes together, deciding for themselves together how they want to use music to heal and to reach the goals that they set. So another type of community building or community music therapy that I've also found beneficial, especially as a music therapist, and advocating not only for music therapy, but also advocating for the needs of participants in the system, is including healthcare professionals in music therapy spaces. So that could be with the families, the patients and families, bringing a healthcare professional within that space. And that allows for healthcare professionals to see those families in a different light, maybe humanize them a bit more, take away that illness for 45 minutes and see them as a whole being, instead of pathologizing everything. So that's one great way. And I found a lot of success in using improvisational music therapy within that space, where I bring in a healthcare professional and really letting that child or young person lead that, and showing that they can lead, they can be leaders in their own healing and health journey, and have them invite the medical professionals into the space, instead of the medical professionals always dictating the spaces that that child or young person or family must be in. It helps to balance that access of power by reversing it for a moment, right? They will still have to do a lot of things they're told as patients through the healthcare system, but it gives them a moment where they have that power. And I think that shows the wider healthcare community the benefit of allowing the needs be expressed by the family or that individual. Other ways are bringing healthcare professionals themselves together without any patients or families. Almost every time I've worked at a facility, nurses have come to me, doctors have come to me, we need music therapy. We need that. Many music therapists have had that experience. We need to feel less stress, less anxiety. Our jobs are so stressful. So how can we show the needs of each person within a wider healthcare system, even though they're not part of receiving that treatment at that time? They're the healthcare professional. There may come a time, or they may have had a time, where they are a patient. So when we're bringing healthcare professionals together, it also helps remind healthcare professionals what it's like to not be a healthcare professional, to be the patient, if you will, to be the client. And through that, the hope in community music therapy is that there is a ripple effect. There's a ripple effect of that, of being able to acknowledge and recognize where that power might be, and how we can, amplify the voice of our palliative patients and their families throughout their healthcare journey. So that's community, some ways that the community music therapy framework might be able to adapt and I've seen some successes in music therapy and palliative care. So another approach to music therapy is called resource-oriented music therapy. Oh, I forgot to mention the names. Stieg and Ansdell are two of the music therapists who've helped to pioneer and also bring together a lot of the bodies of literature of different people who were practicing in a community music therapy framework. Not everyone might call it community music therapy, but they came together and were like, hey, it seems like all of these people are kind of doing that same thing. So their work, if you connect with community work, I would check out some more of their stuff. It's really great. So resource-oriented music therapy, Randy Rolfjord is the pioneer of this type of approach to music therapy specifically. And as is in the title, it's resource-oriented. What are the resources our participants have, right? And I think especially when we're working in healthcare, especially when we're working in pediatric palliative care, where there's so many deficits being pointed out to the people we're working with, it's so empowering to focus on the resources they have, the abilities they have. So one of the ways that I was able to incorporate this framework into my work in pediatric palliative care, and this I didn't really start until Kuwait, which is a bit of a shame. But as we practice more in our fields, we get better and we learn more and we improve. So using an assessment, but that's more of an interview. So I call it like a culturally informed music therapy assessment interview. So I put together a series of questions to better understand how that child or young person and their family use music on a day-to-day basis. So what is their relationship with music already? And how do they use music as a resource? And how would they like to continue using music or change the way they're using music? So that might take a few sessions. That might not happen all in the very first session, depends how much someone's willing to share. But I think it's so important for us as music therapists to understand what our participants are already doing with music before we start prescribing things, before we start suggesting, before we start doing interventions. They might have so many great and helpful ways they've been using music. And what a way to start your journey together than starting with that and acknowledging how they're already doing something so well. Especially when working, I think with that teenage year, that's so important. Teenagers, they don't want to be told what they're doing wrong and what to do. They need to hear they're great, they're awesome, they're in that phase of identity development, they want to be cool. So acknowledging that what they're doing is already such a big step, I think it's a great step into that therapeutic relationship together. Yeah, as I put here, that every person is a unique individual, and spending time to get to know that person through the relationship to music. Now, what can be difficult, especially in palliative care, in my experience, I've worked with a lot of participants who are not speaking. So doing an interview in that context is going to be a lot more about the caretakers, the parents. I think working in Kuwait, a lot of the families I worked with had nannies or private nurses in the home. So I really involved them in this component as well, because they're with that child through their whole routine. So really getting to know how they use music with that person, with that young person already. Are they playing music how frequently, how many hours, what's the volume, those things as well. Is it beneficial? Is it not? And what areas is it not beneficial? Do you find it beneficial in the morning more, the evening, at meal times? So really getting into how music already is being used. And also a big part of that, what music does the family listen to? What do they like? um, and how we can use their preferred music as the relationship moves forward. So also a big part of within resource-oriented music therapy is really that I have found helpful is embracing critical humanism. So it is our duties. So I'll just read the quote because I connected with it in one of the readings. Music therapists have a moral consciousness capable of holding space for and integrating the sociocultural perspectives and experiences presented by those engaging in therapy. So we have to hold space for that whole person, right? We don't want to engage in a what's the word I'm trying, like a toxic positivity of always trying to be positive. Oh, this is great, that's great, this is great. We also have to come at it critically and say, hey, some of those experiences and some of those intersecting identities you might have might be causing a lot of difficulty for you. Let's also bring that in. Let's acknowledge how someone's identity might create discrimination. And especially when we're dealing in pediatric palliative care, we're dealing with children with disabilities. That's just how it is, whether it be they using a wheelchair, they don't have physical movement, or they don't have much control over that. They don't have spoken word. They need to use a walker. I mean, they have cognitive disabilities due to their illness. It's really important to acknowledge how some of those disabilities makes engaging in the world around them really difficult. And then how can we talk about that, acknowledge that within a music therapy space, but then also adapt that space to allow for empowerment. Could be, adapting instruments, adapting the interventions we do so that it is more accessible. And then also sharing that with the wider healthcare team that might be engaging with those participants. I pretty much touched on this, but a huge part as well in resource-oriented music therapy, we have to humanize those who we're working with. And we have to do that specifically for other healthcare professionals sometimes. So this all also ties into the community music therapy part. But if we are really wanting to work in a lens that is focused on dismantling discrimination against disabilities, we really have to go outside of our sessions and do that work. So how do we ensure that patients, participants, and their families are seen as the human they are? Some ways I've been able to do that in my practice as a music therapist is in grand rounds or in those interdisciplinary team meetings where we go over each patient, their case, the interventions, the goals, and all of that. I always use their name. Never patient this or that. I make it a point to do that, remember that they're, oh, I was like, why did I get a thumbs up? Because I'm making a thumbs up, it came on the screen. Some other ways is I always try to bring the discussion back to the strengths of the family and the child or young person that I'm working with. I mean, so many times we'll hear the mother just isn't doing what she needs to do. How many times I hear it, and I'm not a mother, I'm a pet mom, but even hearing it is not a mother is a boils inside, you know, reminding healthcare professionals the complexities that these caretakers have to go through to care for their child, and that they are also human. They're not robots, they're not machines. So if that mother or that parent is struggling, what can we do to help them, right? What other services can we offer? So a huge resource, for pediatric patients is their parents and caregivers. That's a huge resource for them. That's sometimes, in some cases, the only reason that they're still alive is that their parents are dedicating so much time. So if we want to ensure that that resource for that child, their parents, remains and becomes stronger, how can we as music therapists then support them gain resilience? So sometimes I will do individual sessions just with the parent, or a caretaker, and give them space to express that journey of being a parent with an ill child, and using music as a way to build some resilience and resources and other assets to be able to care for their child in the best way that they can. We're doing all right-ish on time, huh? We don't have much time for questions. And then the social justice approach to care. So self-actualization, if you're looking at that, Haslow's hierarchy of needs, which is kind of an old way of hierarchy needs, but that's kind of the top of there when we're our full self. We can't tell our participants how to be their full self, right? They need to tell us how to do that. We're there for the journey. So just wanted to bring that in. So family-based. And this is the last slide, and then we'll be done. We talked a lot about family systems. A lot of this is a little bit repeat, but I just kind of wanted to show how these different approaches and how they're tied into some of those similar frameworks. They might look a little different though. So family-based is that family unit, right? So we're looking at how that family interacts. A family assessment is crucial, like I mentioned, in resource-oriented. I also do a needs-based assessment. How do they engage in music? Each participant, especially if the child or young person has disabilities that may impact how they can engage in music making specifically. How can we ensure that their needs of making music are met, right? Adapting instruments, what kind of tools, digital music making, live music making, all of that. Attention, cognitive, you know, how long can they engage in music therapy? If I book in an hour session and we have a 2-3-year-old who's developmental level of like a 1-year-old, that's just not going to work, right? So that's kind of what I mean from the music therapy perspective. What are the needs of that individual and the family? So we're looking at family-based music therapy. Walsh had a great article. It's not music therapy, but I feel it really ties in with the work we can all do in pediatric palliative care. What are some of the dysfunctional patterns, especially in communication between all members, you know, mom and dad's communication, mom and child's communication, child and sibling, sibling and mom, you know, everyone has a different communication pathway. We talked about the resources. We talked about how families solve problems. And then a big part is how do we strengthen the functioning of not only the individual, but of the family as a whole through music making. And my work in pediatric palliative care, I do a lot of improvisational music making. How did they come in that day? Because we deal with a lot of chronic pain, a lot of chronic issues. So what a child or young person did the week before, they might come in this week with a pain level of 8. Well, last week they were a pain level of 3. It's not going to look the same. So for me, in my approach, I really prefer that improvisational. Let us sit down. Where do you want to do first? Let's start there and really follow the lead of the participants that day. Sometimes in family units, that's when you'll start to see those dynamics. Did the caretaker step in and try to lead? How many times I've heard a parent tell the child, you play it this way. So just, noticing what are those messages being sent to that child or young person within music making. Those messages, those ways of communicating most likely will be the way things communicate outside of that space. So how can we model allowing it to just be? Sometimes could be a goal. We talked about resilience and asset building within the resource oriented, but plays a huge part when we're looking at family-based music therapy. How do we solve problems? So say a sibling wants to play it this way, and then the sick child wants to play it that way. Let's figure it out together. Let's solve this problem. We want two different things at once. And if parents are there, they might say, oh, we all just let the sick child always pick. Well, what does that do for the sibling who never gets to pick, right? So being able to model every person getting a chance to have a say, right? And then it's like a negotiation. It's like you're going to the market and haggling for the best deal, right? But in this case, we are negotiating for everyone to get some space within that session. So I want all of us to play the piano. We all can't fit at the piano. Let's see. Let's see how we can do it. Let's see. Let's try, and maybe we get everyone at the piano. Everyone's laughing. It's silly. It doesn't sound good, but we're learning how to solve a problem. And it might not look as the answer that we want, but we're learning through action and through making music that's okay. We're not always going to find that right answer. All right. And we spoke a lot about identity. So allowing each individual's identity to shine through within those family sessions. It could be also sharing music. I've had some family sessions where each member of the family, especially I had this in Kuwait, where we had parents who only solely listen to Arabic music. And then you have the children and young people who like to listen to Arabic music. Gosh, I learned so much Bollywood songs, listened to so many new Bollywood songs in Kuwait, and then English music as well. So you're finding these younger generations, like they have the internet, they're listening to everything. So some sessions, like let's just share some of the songs we are listening to this week and why we like them. And through that active sharing, we learn about each other and we learn about our family members, why they like things, why they don't like things. And it allows us to get to know each other's individual identity and how it changes. Yeah, so that's it. I guess in conclusion, to tie it up, supporting pediatric palliative patients, overall, I found it so rewarding, or I wouldn't have continued doing it for so long. There's tough days, tough times. I think in pediatric palliative care, especially, we get a lot of unexpected deaths because of the resilience of children. They'll be doing so well. And then it's like overnight, some infection comes up that's not even related to their primary disease, and they just don't make it. So also, which I didn't include in the slides, but is coming to me, I think it's so important when we work in these atmospheres, our own self-care and our own resiliency as practitioners is so important. Know when you're getting tired, know when you need to take a break, and when you need to give yourself some music. Some ways I would do it is before I had any sessions, I would go to the room. I was lucky enough to have my own music therapy space, and I would just play some songs that I loved, sing it while I do my warm up, to get me in a space where I felt full before entering into a space with my participants and their families. So I hope that this offers something that is helpful and beneficial. I think these references are really helpful. They're not all about music therapy. Some of them are just, one of the full references didn't paste fully. But if you search community music therapy, you're going to find so much stuff. But I think also to acknowledge as music therapists, it's okay to pull theories and frameworks from other mental health disciplines and find ways we can incorporate them in our practice. So thank you so much for having me, and for listening. I'll stop sharing.
Yes. Thank you so much. That was a really beautiful presentation. I think you came up with a very different perspective of the socio-cultural, the family part of it, because with pediatric, the family and the caregivers play a very, very important role. We need to understand the cultural aspects and the social aspects, the financial aspects, and how we can incorporate them together in the sessions. It was really good. Thank you so much. We have a couple of questions. One, Namaste, I have a question. I understand that pediatric palliative care includes neonatal group as well. Please do correct me if I'm wrong. I would like to understand how is music therapy administered with the neonatal group.
Yes. So I've done the NICU music therapy training in the States. I did one actually as well. I think it was in Denmark. Amazing. Like search NICU music therapy to get a bit more because I can't go in fully, but there is a breadth of work being done and a lot of research being done. So yeah, you get a lot of neonates. We did have some on our caseload as well who were already diagnosed with the palliative disease in the NICU. A lot of the work with neonates, you have a lot of family systems as well. That's a huge part of that bonding, of bringing parents into that space with such fragile, their baby is so fragile. And so many parents might be afraid. How do I hold them? How do I touch them? How do I show them love? Using music as a space to facilitate that bonding. So having the parents, caretakers sing a song. That's like the mom's voice, the parent's voice. The infant has been hearing that since they were in the belly. So that's a huge part of it, the bonding and using our voice, our singing voice. As a music therapist, everyone's a singer. I don't know if you feel the same way, but when people, I can't sing, I don't sing. Yes, you can. We all have it. Your pitch, your tone, it doesn't matter to your baby. Your voice is like the best. Your voice is number one. So doing a lot of confidence building around singing so that those parents feel confident. There's also techniques of slowly, oh gosh, what's the word? Sorry, multimodal sensory stimulation, where you'll start with one sensory input and you'll add as you go on. And this can happen over the course of weeks, of months. It depends how that neonate responds. And it's a very specific steps. That one is oh, that's been researched a lot by the NICU program out of Florida State University. Oh my gosh, her name is past me. I think it's Jody. But if you look up Florida State
Joanne Louis?
Louis, it's
Joanne
Louis.
Louis? No.
There's Louis and there's one other. Louis is hers is at NYU, I think. And then it's also a Joanne, but with a different last name.
Yeah.
It's just past me, which is horrible. I did the book's in the other room. So it's about that stimulation. How can we help neonates process new stimulation? Because that's one of the biggest things, and do it safely and consistently and healthy self-soothing techniques as they encounter new stimulation. So auditory is a huge part of the world. If that neonate is not hearing impaired, that's going to be one of the first things that they're getting sensory. So yeah, I hope that answers the question.
Thank you so much. That was quite interesting to get those techniques and the way it's being done with NICU. Okay, so we have a few more thoughts, and we're also coming to the end of the session. We have 3 minutes, so I'm just going to read out what we have here. It was a very insightful session. It brought to light the many larger socio-cultural factors and nuances that can influence the work being done in the room. Love the self-care tips for the music therapist as well. Thank you for sharing your work. And someone says, good session. This was a wonderful session. My key takeaway is humanistic approach and family orientation. I think that was the huge takeaway, actually. All the resource orientation as well as the family part of the sessions. It's I think that was very, very important that we look at pediatric palliative care, not just as a child, but as a whole with the family. So thank you so much. And if we have any more questions, I think they'll put it up in the group that we have, and I'll get it across to you. Thank you so much for your session today. It was really insightful. Thank you.
So
Bye.
much. Bye. Thank you.